Hello everyone, my name is Elizabeth Marlowe. I'm one of the nurse practitioners with the San Francisco County Jail, and welcome to our first episode of Beyond the Policy, Critical Thinking for Nurses. And I'm really excited to have our very first guest, Nicole Una, who is a nurse practitioner working on CPOD, and she's going to talk to us a little bit about syphilis.
Hi.
So welcome, Nicole.
Thank you.
Thank you for being here. So Nicole, what are the top 3 things nurses should know about the current syphilis epidemic in San Francisco?
Okay, so first, the biggest point that I want to impress upon everybody is that San Francisco County has the highest rate of syphilis nationwide. California as a state is the second highest rate behind Nevada. But in San Francisco itself, we have, unfortunately, the highest rate. The CDC and the Public Health Department in San Francisco has been looking into why that may be the case. There's a thought that some of these transmissions and increase in especially the rate amongst heterosexuals is associated with the increase in the past few years in meth use. And the rate amongst heterosexuals has doubled since 2013.
Wow.
There's been this big influx of meth in the West Coast over the past few years as well, more so than they've seen in the East or the Midwest, and that's coupled with also an increase in injection drug use, or individuals who are having sex with individuals who inject drugs. So that's where a lot of these rates seem to have been increasing from. There's an association with meth as a stimulant, which is a kind of a disinhibitory drug, and so people have increased their high-risk sexual behavior, are not using barrier methods, exchanging sex for drugs or money, which unfortunately is pretty common amongst our patients. So, syphilis is an interesting infection. It can affect people in different ways. There's at different parts in the course of the disease, it can present itself in with different symptoms. And women in particular are at risk for exposing fetuses to congenital syphilis. So that's transmission from mother to child or mother to fetus, and those outcomes are pretty significant as well. A fetus or a child born with neonatal congenital syphilis can present with blindness, have severe developmental delays, or even be born stillborn, or have a fetal death. So it's pretty significant, and a lot of our female patients in custody are of childbearing age.
Yes, and that's why we are encouraging everybody, for women, to just go ahead and order the rapid syphilis test. And would you order the rapid syphilis test even for women who are not of childbearing age?
Absolutely.
Okay.
Across the board, it's now. Essentially because the rate is so high, and since I've started working in jails, I've seen a couple cases amongst those who wouldn't be deemed as high risk, and people, there was one individual who was over the age of 70 that we had a positive
Wow.
test. Yeah.
Whoa.
Yeah.
Oh my God. Well, life goes on, doesn't it?
Absolutely. Is that early detection and treatment has the best outcomes. So we really want to kind of get these individuals tested as soon as we think infection may have occurred or transmission, and treat them so they can be cured and not.
talking about the first test. It's just the RPR screening, and it could be rapid or it could be regular.
Absolutely.
Or venipuncture.
There you go. Yes. So that's first line. Negative, great. We're happy. Positive doesn't necessarily mean the infection is acute. So the next step is something that's called a triple Needles test, which confirms that the RPR is actually reactive. So it'll be a secondary reactive as well if it's an infection. And then after that, there's also a titer. So the titer is, some kind of dilution, and it basically tells us how concentrated the infection is in the blood. We can't stop there. Basically we've had this information, it's positive, there's a titer. Before we are initiating treatment, we now have to talk to the patient. So the big next question to ask is, have you ever been diagnosed with syphilis, and have you had treatment? If they've been treated before and the titer is essentially the same, we're going to say they've been treated, or I'm sorry, the titer is the same or less. They're essentially considered treated, and we're not worried. We're reassured. If the titer has gone up, I believe it's fourfold, but don't quote me on that. If it's gone up, then we might consider that a new infection. If there's a titer and they've never had a titer before, we're going to say it's also an infection. We don't stop there. In most cases, or any new infection, we actually are consulting with City Clinic. So they are very helpful because they have access to statewide records for any syphilis testing and treatment. So we always consult with them before we initiate any new treatment on somebody.
Yeah.
So the gold standard for treatment is penicillin G benzathine. That's the bicillin. It's 2.4 million units IM. So it's 2 big syringes in either muscle, shoulder, or the gluteus. People don't like it. It's painful, but it cures syphilis. So I should say that's the medicine the medicine choice. There's a couple different ways to treat syphilis, and not make it too complicated, but anybody who's confirmed that we're pretty comfortable saying that their infection happened within the last year. They had a negative RPR within the past year, or they are pretty certain, yes, I only had sex with one individual in the past 6 months or past year. We can be pretty confident that they have either primary or secondary syphilis, and that's a one-time treatment. So that's just that medicine one time. If we are not sure when they became exposed to the infection, they don't really have any symptoms, or they may have some symptoms that we're worried about, things like ocular or neurosyphilis, also known as tertiary syphilis. We're going to go ahead and treat them either for tertiary or what we call late latent syphilis, and that is a 3-part series, and that's the same medication, that 2.4 million units of bicillin, once for 3 weeks, 7 days apart. So it's the same day, 7 days apart. Again, it's got very good curative rates, but we just have to know that we're extending the treatment longer. We're not going to get into this, but if somebody has a penicillin allergy, we're going to do some investigation and see if we actually can go ahead and give them penicillin. Otherwise, we can give them oral medications, but it's just a longer duration, and we don't get the follow-up, so we don't particularly like or don't want to do that if we can avoid it. Unfortunately, we also know that a lot of our patients only really get or receive medical care while they're in custody. So we're the only point of contact and screening and treatment. So let's get them while we can, because like I said before, we're in an epidemic and we need to stop the transmission. And if we can do that with one injection while they're here, while they're open to it, let's do that. And again, like the individuals who have had the infection for longer term tend to fare worse.
Yes.
The other thing I was going to mention is, the early symptoms are kind of vague. We don't really have, it's like any kind of infection, fever, malaise, maybe some achy joints.
Yep. Sore throat.
The big one that we are often talk about is this rash. Because it's kind of this diffuse, and it's a diffuse rash, but it also presents differently in every individual.
Yes.
It's really common as the chancre, which is typically the first sign of syphilis. Unfortunately, it's a painless lesion, and it can happen. It can occur anywhere, and people may not notice. They may think it's just like I have a sore, an ulcer, or like
a little canker sore.
Exactly, and so it may be missed, and it often is. So typically, when we're diagnosing somebody based off of symptoms, it's not necessarily the chancre that we're seeing.
Yes. Yes, there really isn't a classic presentation anymore.
No.
It's really complicated now.
Right. So yeah, we know there's an epidemic. We know San Francisco has the highest rates in the nation. We know it's amongst heterosexuals, and particularly women of childbearing age. And we've got a lot of patients who are not seeking medical care outside. So really, it kind of behooves us to be the ones testing and treating.
Yes, and you can always just go ahead and order the test, and we can change it. Don't be afraid to order the test. Go ahead and do it. Well, thank you so much, Nicole, for all your wisdom and experience and insight, and hopefully this will be helpful for you. And again, feel free to reach out to any of us. We're happy to talk with you. It's how we learn as well. And don't forget to print out the little printable on the bottom of the screen, because that will have a summary of all this information that we talked about today. And thank you, and thank you.
Thank you.